said, is a program that is bridge the gap that has been identified between best practices in service delivery, veterinary service delivery, and what is obtainable now. And one of the areas that Kotog is concentrating in terms of skills and knowledge for the younger interns and veterinarians is record keeping. Record keeping, suggesting that whatever is done, the record is kept, properly kept for official references.
Kotog, therefore, is here to build clinical competencies of our young professionals, colleagues, and it is a way of providing them with those skills that the market will need in terms of animal health care delivery. We have thousands of well-tutored colleagues, but the missing thing there is that they are not grounded when it comes to skills and practice, and that is what the industry will actually require going forward. So Kotog will be a platform where every career, every young veterinarian can apply and then get the needed skills in terms of field practice, in terms of clinical practice, in terms of food safety and public health practices, in terms of research, in terms of business plan writing, but also, making sure that whatever you go out to do is one that you are proud of the bottom line figures at the end of the day, at the end of the month, and then at the end of the year.
Good morning, everyone. Can everyone hear me?
Yes, we can.
Thank you, ma'am. Good morning. You're welcome. So today we are going to be having a session with Dr. Adenike, and she's going to be talking to us on advancing veterinary care, the crucial role of imaging in diagnosis and treatment. So we are going to be having someone that has the knowledge, the wealth of knowledge to give us better ways, better approach we can diagnose using imaging and have a better treatment. So this is the agenda. We're going to have our participants introduce themselves in the chat box, tell us where they are joining us from. Then we would have to introduce the guest speaker, which will be done by me, Dr. Bolanle, and the presentation by Dr. Adenike, who is going to be talking to us about advancing veterinary care. So sorry about this, Dr. Ezewakunobu will not be joining us today, but Dr. Omotola is going to help us with the participatory and discussion parts, the question and answer parts. Then we're going to have Dr. Bala Mohammed helping us out with the vote of thanks and other announcements. So without wasting too much of our time, we're going to be introducing our guest speaker, Dr. Adenike Olatunji. She is a 1995 DVM graduate of University of Ibadan, who holds a master's and PhD from University of Ibadan. She's a radiologist who started a career in a private practice before joining the University of Ibadan, VTH, in 1999, and she started to teach in 2008 when she was employed, and then she moved to the Department of Veterinary Surgery and Reproduction, and now she is fully in the veterinary surgery and radiology. She has further training opportunities in Canada and United States under the MacArthur and Fulbright GSD programs. I must say that she's also a fellow of the College of Veterinary Surgeons, Nigeria, in diagnostic imaging, and has had several opportunities to teach the School of Veterinary Medicine, University of Ghana, Legon, or Legion, I don't know, correct me if I'm wrong. She has written over 40 articles in the learned journals and books, and she is a proud mother of 2 lovely daughters. You're welcome, Dr. Adenike, and over to you. So I'll be sharing at your screen for you. So you just tell me to do next slide then.
From here?
Yes. Thank you, ma'am.
Can I share from here?
Sure, you can.
Okay. I think okay. Good morning, everyone.
Good morning, ma'am.
I'm waiting for my screen to show up first. Okay, great. So good morning, everyone. As you've heard, my name is Nike Olatunji Akure, and I teach surgery at the University of Ibadan, Faculty of Vet Medicine. I teach surgery and mostly diagnostic imaging. I first of all want to thank Dr. Bala Mohammed for the opportunity to present this talk. We all know that I'm a teacher, and this lecture series is known as Connecting Town to Gown. So this is me trying to sort of like bring you up to speed, those things you already know as clinicians, just trying to remind you of them and see how we can both do better. So it's known as the Connecting Town to Gown lecture series, and it's done by the Managed Services Limited. It's also called a clinicians roundtable. So basically, those of us who are on this meeting are mostly, and so we really already know quite a bit. But we want to talk about advancing veterinary care, the crucial role of imaging in diagnosis and treatment. We all know that when cases are presented, we follow a plan, so to speak. We take history, we do a physical exam, we do a tentative diagnosis, take some laboratory samples for laboratory diagnosis, and we begin tentative treatment. Upon some information from the lab diagnosis that we've done, we institute definitive diagnosis and begin definitive treatment. One want us to be aware of is that diagnosis is king. For the clinician, the path to easy treatment and better treatment results is through diagnosis. There's nothing that can be done very well without accurate diagnosis. I always make the joke that there are clinicians who can look at a patient and diagnose kidney failure, liver disease, and all of that. No, those are jokes. They are not the real thing. The real thing is for us to do a tentative diagnosis based off of history and physical exam, and then to do definitive diagnosis by taking samples or making images and then definitively treating. Now, what are the diagnostic imaging modalities that are available to us? I must, in this side of the world, we are challenged by machine deficits. But one thing I have learned from over 15 years of trying to do this work, that where there is a will, there is a one day, if you keep at it, you will come in contact with that client who cares enough to want to do the right thing, and you will come across somebody who will enable you to do it. So the imaging modality that are available to sonography, fluoroscopy, ultrasonography, computed tomography, magnetic resonance imaging, nuclear medicine, and positron emission tomography. Now, when I say available to us, if you are willing and able, you are probably able to use all of these. But the truth is, we as clinicians, we must balance, economics with medical treatment, and also sometimes it's just not feasible. But one thing that I do know is that if you keep trying, you will find that you will have more opportunities to use imaging. And as you use imaging, it will become easier. We all know about radiography. I know that almost every clinician has access to radiography. It's the primary image modality of choice. It uses whoever is going to be looking at images must have some idea of what those differences are to be able to know when there is pathology. Now, one of the basic understanding that you must have with radiography is that you must take two views at right angles to each other. Two views at right angles to each other cannot be overemphasized in radiography, because radiography is a two-dimensional image or three-dimensional structures. So if you don't have a sense of the third dimension, you will not understand the full story. Now, if you saw the first picture on my screen, you would think, oh my, this mommy lion is eating her cub. But the truth of the matter is, when you look at a second view, which is at right angles to that, you will understand that she's only carrying the cub away from danger, probably. The second picture that I used to depict this is the Prince of England, future king. If you look at the first picture, you would think, oh my, the prince is being lewd. But that's just part of the story. Another view showing you a different angle of the prince tells you that he was actually trying to say three rather than a lewd gesture. Now, in radiography, like I said before, you always have to take two views at right angles to each other, because there is a sense of the third dimension that is missing in the two-dimensional structures that radiography will show you. Now, as we go on, I will show, more of this. Now, one of the important things that I like to remind clinicians about in radiography is when you are presented with fractures, sometimes the fracture is not the problem. It is getting an image made. Because many of us do not have on-site radiography facilities. You have to move the patient from one place to the other. Now, if you have a fracture like the one showed in this slide, you see the really sharp points of the broken bones. That in itself can constitute a hazard and can cause death by, just severing an artery, or, just changing the dynamics of the case. So one of the things I want to encourage clinicians to do when presented with fractures that require imaging is to bandage prior to imaging. Just safely cover the fracture so that the animal can be safely moved from one place to the other without, exacerbating the fracture. The other thing that I'd like to point out is you must take serial images, pre-operative images, post-operative images, weeks after post-operative, so as to help you understand how healing is taking place. It's very, very essential. Some people will say, oh, radiographs are not supposed to be taken so frequently. That's not the case with us, because we don't have access to our patients all the time. And some of our clients are not as invested, so to speak, in the care of their pets as we are. So it's important that when you do a surgery, maybe to repair a fracture, you check, 2 weeks after, 4 weeks after, just to make sure that your patient is doing okay, or continuing to be well. One of the things that I like to talk about is how images are read across the world. One of the things that many clinicians do not, maybe because our training in imaging was not really deep before now, one of the things that we are not aware of is that there is a worldwide conformity for images, the way images are presented. When you present images in that lack conformity, you make it difficult for anyone to assess those images and to report them, so to speak, to tell you what is going on. Now, if you're going to be sharing images, radiographic images, for instance, and you have a lateral image like the one on the left, the head of the animal must be towards your left. The cranial part of the animal must be towards your left. For DV or VD views of animals, the head must be to the north. This is the international standard for presentation of images, so that when you share images with people from around the world, they already have a sense that you know what you're doing. Looking at thoracic images, I always counsel that we check, I always advise clinicians to look at the entire picture and look for Röntgen signs. I remember asking my students what Röntgen signs are. Maybe it's the way I called it or something. They were like, we don't know. But Röntgen signs are things you already know. The location, the number, the opacity, you look at things that you are aware of as normal and be sure that they remain normal. When you look at a thoracic radiograph, for instance, you want to check that you have, in the dog, you have 13 thoracic vertebrae and you're not missing any of them, because sometimes that's the issue. And if you don't check, you will miss out on the pathology. Like I said before, sometimes when there is, when contrast is not as much as you desire it to be, you may not be able to evaluate parts of the animal, like in the GIT, for instance, in the abdominal cavity, many of the organs in there are soft tissue. But if you want to, further assess the differences between segments of the GIT, you're going to need some contrast media. Sometimes road traffic accidents occur, and internal injuries are of the kind that you really cannot detect by radiography. Contrast radiography is something that you can use. So you have the positive using things like barium, and the negative using things like gas. Like I said before, in abdominals, everything is soft tissue. So it's kind of difficult to, if you don't have a good radiographic image, it's difficult to diagnose. But one of the things I constantly tell clinicians is, when you bring the history that you have received from the owner or the handler, and you bring that together with your physical exam, by the time you get a radiograph, you will know where to look, how to look at it. Like in this case now, this animal has uroliths. So there will probably be some history of maybe bloody urine or anuria or stranguria. And of course, when you look at this radiograph, one of the things you're going to be looking at is the bladder, and if there is anything wrong in that area. In this radiograph, I included this radiograph because many people, think that the only way they can diagnose pregnancy is by ultrasound. In late pregnancy, you can look at late pregnancy with a radiograph. And if you look closely, you will see puppies within this particular radiograph, and you can see that the viability even of the puppies can be determined. In this radiograph, I just wanted to show us the spleen, popping up just below the intestinal lobes, because many of us think, oh, the only way you can image some certain things is only via ultrasound. One of the things that we constantly fight about, some clinicians and I, is them wanting an ultrasound when a radiograph will do. I keep telling them that a radiograph is the primary modality, and it is one of the best because it gives a bird's eye view of everything that is going on. Even some things that you're not seriously looking at can show up on radiographic images. Now, fluoroscopy is the use of, again, X-rays, but low-grade X-rays this time, to evaluate moving parts of the body. It's usually referred to as X-ray movie. Usually it is used when diagnosis of moving parts is required. You are presented with a case, the animal vomits every time it eats. There is no obstruction. There is nothing physically that you can detect that is wrong. But you've tried everything, and this animal just keeps throwing up every time it eats. Fluoroscopy is able to determine what's going on in such instances. So you can use it for the esophagus, the heart, and the GIT. I hope this works. Oh no, I'm supposed to click. Oh, I'm sorry. I had a fluoroscopy on there. Oh wow, it's not working. I'm sorry. Oh, come on. It's not working. I'm sorry. I was hoping to be able to share a fluoroscopy with you. Okay, so the next imaging modality is the use of sound waves, ultrasonography, the use of sound waves to image organs, and it's based on the pulse echo principle. It is useful for diagnosis of internal organ parenchyma. You want to look at the spleen, the liver, the quality of the parenchyma, some blood derangement within the organ, or some masses within the organ. All of these are best done by ultrasonography. The only issue with ultrasonography is that it's so user competent dependent. If you're not, if you don't know what you're looking at, the ability to diagnose will be limited. And ultrasound is so vast that I've spent more than 15 years learning, and every day I come across things that I'm just knowing. So it's such a user dependent modality. This though is one of those imaging modalities that is readily available to all of us. Small animal clinicians need machines of about 7 to 9 megahertz. But I find that 3 to 5 megahertz machines are commonly available or affordable. And this should not stop us from, utilizing this modality. It's best used in diagnosis of the liver, the spleen, the kidneys, the bladder, in pregnancy diagnosis, in assessing fetal viability, and in looking at masses, trying to differentiate fluid-filled masses from, solid masses. This is what one of those portable ultrasound machines looks like, and this is a machine I've been hungering and thirsting after. So it's a lovely machine. It has several probes. It has Doppler. This is what the probe looks like. The probe is actually the most important part of the machine. It has piezoelectric crystals that help, to send sound into the body, and also to receive the echoes and transmit the echoes into images. This is my own machine that I've had for a number of years now, and this is a pregnancy diagnosis. I don't know if you can see, I always show the spine of the fetus. Most times, late pregnancy, you can assess the spine of the fetus. It looks like a rosary. In this particular ultrasound, you can see the rib cage of the fetus, and you can see where the heart is. I always make the distinction that the heart of the fetus beats like a Mercedes-Benz sign. You know, it opens and closes just like a Mercedes-Benz sign. This is the bladder. The reason I have two pictures of the bladder here, most times urolithiasis can be diagnosed by ultrasound. If you look at the bladder and you see crystals within, I've showed two images of the bladder. This one was done with a 79 megahertz machine. This was done with a 3 to 5 megahertz machine. So it's not that you will not see anything. It's just that the quality of what you will see will differ. So we should not be put off by the fact that we don't have really cool machines. We keep learning, and when we get to where the cool machines are, we will do better. This is the left kidney. This is the spleen in ultrasound. Of course, we talk of echogenicities. The spleen is usually hypoechoic, and areas that are black are known as anechoic. They are returning no echo at all. Okay, so the advanced imaging techniques that are available to us, one of them is computed tomography. It also uses X-rays, and it takes multiple slices of the body, which are then reconstructed by the machine. In computed tomography, you don't have to worry too much about, reconstruction of the image in your head, because and taking two views at right angles to each other, because the machine does all of that for you. And of course, the higher the slices the machine has, the more detailed your images are. And it's very useful for all types of organs. It's superior to radiography for things like fractures and musculoskeletal conditions. All of the images that I will show you are images from things that I've seen over the years. Like this is a longitudinal image. This is the sagittal image. At that point where the line crosses is where this image is showing, and you can see many of the conditions of the spinal cord are easier seen with CT, because areas where you have compression and things like that, they're so subtle that on radiography you may not catch them, but on CT it will show you very clearly where the issues are. Like in this image of a mouse where you have contrast CT being done, the images are showing you at the level of the kidneys, and then you can use contrast you can use the machine to enhance the image that you see. You can show only the blood vessels. You can decide to show only the muscles, any area, depending on what you put in to the machine is what you will get back. Another approximately 63% of hydrogen molecules is what our body is made of, and it measures the response of atomic nuclei of body tissues to high frequency radio waves when they are placed in strong magnetic fields. So you have the nuclear magnetic resonance of hydrogen molecules is used to create the images that you see. This is again superior to other imaging methods, and it is used in brain, spinal cord injuries, bones and joints, heart and blood, internal organs like the liver, the kidney, and for even very, very priced animals, pregnancy diagnosis. Like in horses, sometimes you have joint issues in horses because they are so, they are so precious, they are so expensive. You don't want to do any hit or miss with them. Like this is a joint mouse in an equine fetlock where you have osteochondrosis.
David, don't go there.
you want to diagnose properly so that you can treat. And then of course the types of images that we get, they are so specialized. Look at this is the dog head. You can have a sagittal view, you can have a lateral view, you can show a 3D depending on what you want. One of the challenges with using MRI is the fact that we in Nigeria, at least, as far as I know, there are mostly human centers, and except for things like research, people are not yet using MRI for diagnosis. But the truth of the matter is we're heading into a new dispensation in the veterinary industry where people demand answers for conditions of their pets. And so if you have access, if you can get somebody who can allow you access, there is nothing wrong with trying to do this. The next imaging modality is nuclear medicine or scintigraphy. In scintigraphy, radiopharmaceuticals are used to make the patient radioactive, and then their radioactivity is assessed using a gamma camera. The distribution of radioactivity relates to the pathophysiology of the patient's disease. You can use nuclear medicine to diagnose potocarpal shunts, to identify and treat or to plan treatment of hyperthyroidism in cats, to identify bone lesions and brain and kidney lesions. This is the gamma camera that I have had the opportunity to utilize. We were doing this study in horses where we were looking at the impact of racing in horses on their limbs and how, the racing that they do can predispose them to lameness later in life. If you look at the images that we're looking at, you will see areas that are deeply black. Unfortunately, the nuclear medicine, the images are not very big or large that you can say, oh, this is this or that is that. What we evaluate are areas of hot spots, where there's too much bone growth, like in this study. I included this because one of the challenges of nuclear medicine is that the radioactivity must be contained. The animal cannot leave until after the time of the half-life of the radiopharmaceutical that it has been fed. You can do kidney scintigraphy. This is for to assess glomerular filtration rate. Again, several images. They are not as clear as you would want, but you can see the hotspots. Any areas where you have red, showing hotspots where there is hyperfunction. Also, you can do bone scintigraphy. In this instance, we have osteosarcoma in the left knee of this dog, and it shows up in bone scintigraphy here. Again, you can use, like I've said before, thyroid to assess the thyroid. This is what a normal thyroid scintigraphy looks like. And then you have two cats that have thyroid adenomas. And when they were, given the radio pharmaceuticals, you see the hot spots showing up in the thyroid. One has a unilateral adenoma, the other has a bilateral adenoma. So all of these things are possible to be diagnosed with imaging. Now, for positron emission tomography, it's used to reveal the normal and abnormal metabolic and biochemical activity in tissues and organs. It uses a tracer, like a small amount of a radioactive drug, like fluorodeoxyglucose, is best for detection of early signs of cancer, heart disease, and brain conditions. One of the things we must understand is that the world is not waiting for us. They're not waiting for us to catch up. Where we're thinking radiography, ultrasonography, people who are using PET and CT, they are even combining both to do greater things. The challenge of diagnosis is constantly evolving. So nobody is waiting for, African vets to catch up. They're just evolving and doing bigger and better things with in clinical diagnosis. And that's why it's important for us to keep abreast of those things that are available. Yes, we may not have access to all of them, but we need to know about them. We need to be able to speak knowledgeably about them. Now, this is positron emission tomography. You can see the tracer shows up, this is where it's injected in the limb of the animal, and it shows up in the brain, in the heart, in the kidneys, in the bladder, all the areas where there is some metabolic problem, the tracer will show up in those areas. So diagnosis has gone beyond us just, imagining that, oh, this is something that is impossible or something. No, now the most important part of this talk is for me to give a charge to clinicians. One of the things I am seriously incensed about what that clinicians do is not taking baseline data. When a dog comes to your clinic for the first time, either as a puppy or as an adult, one of the things that you must do is take baseline data. The same way you take the temperature, you take a blood sample, you should take baseline imaging data. Take baseline data so that when something happens, you have something to compare with. It's very, very vital. If we do not take baseline data, we will eventually get to a point where we don't have normal data to compare disease conditions with. So it's very, very, and because of the differences in the species that we handle and the breeds that we handle, baseline data can make the difference between calling something that is normal pathology. Then it is important that clinicians refer cases. When I say refer cases, I'm not saying hand it over to someone else. I'm saying ask for help, ask for a consult. Oh, I'm looking at this case. Do you have any experience with this? Have you seen any of this? Just talk to a senior colleague, a colleague, someone around you, because that can make the difference between, you doing the right thing for your patient and just missing the entire thing. Many, many times, I pass at the VTH, I pass the small animal clinic, I see a case, I come in and I give my 2 cents about what's going on. Not because I was called, but because it is important to me that we share information about, what we know so that we can do better with handling our patients. Of course, I cannot shout about diagnosis enough. Diagnose before you begin to treat. Diagnose. When you are presented with a case, every opportunity for diagnosis, please take it. Don't assume that, oh, when you're done doing this, some of what you do may alter what can show up in diagnosis. So please, if you have opportunity, please diagnose. And again, don't let machine deficits scare you. If anybody is supposed to be, scared by machine deficits, I think it's me. When I started teaching, we had no functional radiographic machine. We had no ultrasound, but we've come a long way from there. And so don't let machine deficits scare you. I remember years ago, I had a master's student who wanted to do CT in turtles. It seemed like something that could never be done, but we did it. And today, that's a reference that other people can, work with. I remember I piggybacked on the Pangolin Society in UI, I piggybacked on them and I did some contrast studies in pangolins. If you look up contrast in pangolins today, that's one of the reference materials you will find. So don't let machine deficits make you say, oh, I'm not going to do this. Then we need to stop relying on anecdotes. Oh, that's a liver disease, just by looking. Those are anecdotal. They're not things that are, rooted in science or reality. We need to stop that. It's okay for, people who used to practice or who have a lot of wisdom and, to come around and give their 2 cents. But please, let that not stop you from actually looking for the science. And then remember the veterinary oath. You're supposed to continually learn, continually upgrade, continually improve your information. Ensure that those things that you are sworn to do, you keep doing as clinicians. And when I say be safe, I mean be safe. What I mean by be safe is don't be the test case. There have not been many cases, court cases concerning our handling of our patients, but don't be the test case based on what you do. Imaging can take, when you keep records and you do the right thing, it can take the strength out of any case that comes to you. When you show them what you have done, how you reached your diagnosis, what informed the choice of therapy that you did, all of those things can, protect you. And that's what I mean by being safe. So here, I'm done with my talk, but I have this shameless plug. I have a vet diagnostic imaging textbook for undergraduates out, but it's a great resource for clinicians. And I also do trainings from time to time. This is the advert for the one that I did in February. I'm hoping to be able to do more as time goes on, because I am so passionate about diagnosis, about imaging. It's important because it is such a resource. It's almost like witchcraft. You can look into the animal and kind of like pinpoint what it is that is going wrong, and it will help you in doing better with treatment. Acknowledgements. I need to acknowledge the Dean of the Faculty of Vet Medicine, UI, Professor Olufinka Ola Davis. She's such an encouragement to me every time, asking, what more can you do? How can you do it? I am really grateful. I want to thank Dr. Bala Mohammed, who has been taking care of me for many years, many years before now, when we were doing the our fellowship at ABU. We did our fellowship together. I remember he would just say, what are you going to eat? And he will call somebody and make food available. Thank you so much, Dr. Bala, for your care of me. I'd like to thank Dr. Puspa Ramlu of House of Pluto. Many of the images that I used are from her. She's constantly, interacting with me, asking me questions, and, making me do better. And she's such a wonderful clinician herself. And I think both of us just, we rub minds, and it's beautiful. Thank you very much, Dr. Puspa. And also she's my business mentor. I'd like to thank Dr. Folusha Balaji Alabi, who constantly does great work. When I look at young clinicians, that's the kind of energy that I want to see, constantly wanting to do better, wanting to know more. She challenges me as I challenge her, and I'm really, really grateful for her. I'd like to thank several clinicians across Nigeria and Ghana. My teachers and students, all of those who have impacted me on the journey to, where I am today. I'm really, really grateful. Okay. Oh, wow. It's not, what's going on? My screen is not moving anymore. Okay. Oh, Dr. Bolanle, hello. Okay, let me stop sharing and see if I can share again. Okay.
Hello?
Yeah, I was just rounding up. I know I have 20 minutes. I don't want to overshoot the time.
Thank you so very, very much, Dr. That was powerful and impactful. Thank you so much. Who else would have done it better than you when it comes to diagnostic imaging? You've been my lecturer, and I know you've been. Can you see me? You've You've been very good at this. Thank you very much for this powerful presentation. So my name is Dr. Omotola Sholagbademosi, and I'll be anchoring the question and answer session. So if you have any question, kindly send it to the chat box or raise up your hand and I will unmute you to speak. Any question? Okay, let me check the chat box. I think the questions are already coming. Okay, there's one question here for you from David Daniel Boja. So what's the cost of the book and the training, ma'am?
The book is 5,000 naira. And the training, it depends on, logistics. What do I have to put together and how many people come together? The last time it was 25 for ultrasound. It was ultrasound mainly. And I think, I don't know if there's anybody here who was at the training. Some of them report that, they've improved in their use and understanding of ultrasonography. So I don't know, maybe if you can get somebody who has gone through the training to tell you what they were able to gain from it. But I assure you, it is just the cost of doing the training that, that I charge. You understand? I make sure that it's basic costs so that you're not putting out too much, because I really, really want people to use diagnostic imaging. I'm hoping to do one on radiography soon, so that people can learn how to read radiographs and what to ask for when they require radiographs as well.
Okay. Okay, a lot of comments are coming in for you from Olufemi George from UK. He's saying that he is proud of your work. Very well done and Oxford. Also, a lot of people are also asking who would love to have the training as well. So you can send her a mail or just send her direct chat. So I'm still waiting for your questions. If there is anyone who wants to ask question, kindly raise your hand by clicking on the hand on the chat. Or any comment as well. Excellent presentation, well done. That is from Professor Olufunke Ola Davis. Thank you so very much.
Thank you,
Any comment from you, ma'am, Professor Olufunke Ola Davis?
Okay.
Would you like to share?
Okay, thank you very much for this privilege. Let me first thank Dr. Bala for this platform. It is despite the fact that I am not in surgery and radiology, but yet I've learned so much even this morning. So let me thank Dr. Bala for this platform and also appreciate the facilitator, Dr. Adenike Olatunji Akioye. If you talk about radiology, here, she gets the best. So, and I'm not disappointed this morning that she killed it. Let me just use that word. She killed it. Well done, well done. And more grace. Thank you, everybody, for coming too.
Thank you,
bye.
Thank you so much, ma'am, for that wonderful comment. Okay, any other person, question or comment?
Okay, maybe I can ask clinicians, what are the imaging modalities that you're using right now? What are you able to use right now? What's available to you right now? Any clinician can please, talk to me.
I think I will want to answer this basically before I come back to thank my teachers, my professors, and the presenter. Currently, what has been very much available for ultrasonographies. These are two major ones that we actually use very often. But like you said, we've had the opportunity where some of the clients from the diplomatic community will drive you really hard, and we had to obtain so many times from the human facilities MRI and CT scan, and it's a little bit costly, because even for X-ray, each time you move into their facility, they tend to charge for animal patients much more than the human patient, and it's also the same thing with the CT scan, but we get it easily here, where you can just have an understanding with down. So thank you so very much.
Okay. Yes, I know radiography you have a challenge of diagnosis and you are willing or able, having, the resource in humans is something that makes it easy for us to piggyback on and just utilize those resources as often as we desire. Here in Ibadan, having the University College Hospital close by is one opportunity that has helped me in my own personal research to be able to piggyback on their CT and be able to do a few things. I have a colleague who is in radiology there, who I can call up and ask the favor that, oh, I need to scan these animals, and who helps to do that. Thank you.
Thank you, ma'am. There's a question for you from Dr. Uyanu from Wari.
Okay.
She's asking if bandaging, as you rightly advised, doesn't affect the real presentation of the fracture.
No, it doesn't. Imaging will go through your bandage. I don't know what kind of bandage you utilize, but the risk, the risk of a fragment of bone, piercing an artery and leading to death is so real, because we don't have some of these radiographic machines on site. You have to move the patient from one place to the other. And in the process of moving that patient, a closed fracture becomes an open one. And even the bone can cut anything, and before you know it, you're dealing with a dead patient rather than one that you're going to image. So bandaging, if you have a bandage around a fracture, the x-rays will go through and you will still see the fracture clearly. The bandage is not going to interfere with that. Even if it is POP, it will still go through. Do you understand? So it's important for us to at least bandage, so that we can preserve some of these patients that we lose just from inadvertent things.
Okay, thank you very much for that answer. Bandaging will not affect the image of the picture. Any other question?
I see a question from Favor.
Samuel. Okay.
Yes.
Asking, what do you do when you have a client that is refusing diagnostic imaging, or he or she can't afford to pay the charges?
This is it's a really good question, because in actual fact, some clients will come and say, oh, I cannot afford it, or no, don't do that, just treat, don't worry. The truth of the matter is you cannot go beyond the requests of the client, but at the same time, you must do as much as you can for the patient, because your first allegiance is to your patient. Yes, you have to go through your client to get to your patient, but your first allegiance is to the patient. So most times when you have cases like that, I am privileged to be in a tertiary institution. When clients come and they say, oh, I can't afford it, I can overset the costs because I can use the animal to teach. Do you understand? I can then go ahead and defray part of the cost. But for a clinician who is in a one-man practice, that may be difficult. So in such instances, you do as much as you can, and then you let the client sign off that they were the ones who rejected your plan, your treatment plan or your diagnostic plan. Let them sign off so that it is documented, because we know some clients can be funny. They will say they can't afford it. They will go and come back and say, hey, the dog died because you didn't do this, you didn't do that. Always have a backup where the client has something signed, where you outline the plan, and if the client says they cannot do it, just have them sign off that this is as much as they are willing to do for your own protection.
Okay. Okay, so Dr. Bala, you want to add something? Okay.
So when you earlier talked about a plan,
yes,
for diagnostic image is
I'm sorry, I can't hear you, Dr. Bala.
Of pathology, I think the easiest and the most apt that you could use is imaging. And therefore, there are certain disease conditions that you may need to just hands up if they opt that they don't want to do the the imaging.
Oh yes.
No matter how costly it is, because you are not going to get. Take for instance the osteosarcomas. I mean, the easiest way you can pick it in terms of just getting it, you just have to have that radiograph, and then you look at it and you can demonstrate and say, this is it. And the presenter also did mention, if you also look at some other aspects where you need to monitor the progress of whatever treatment you are deploying, you cannot do that without, in most cases, like for fractures and what have you, you can't do it by taking blood sample or any other thing. No. It must be that you have to have that imaging to knowing if healing is happening as actually planned. So what we do as part of what we do here every day, we try to make a plan, like you have rightly said in the lecture. Once we do that plan, we try to now itemize and price it. And then the ones that we think will cause a little ripple, we present that as if that, I mean, yesterday, a Scottish brown cat was presented pregnant and with a case of dystocia. And when we check, it was looking bloated, and the only way we could confirm was the x-ray. And then we immediately saw 3 features there, whether alive, and then we now double confirm using an ultrasonography. Great. And that the 3 of them were still viable before we immediately ran into the theater to carry out cesarean section. So that is how it is. But also we must also have a change of mindset amongst practitioners. the mere fact that you don't have these facilities today does not mean that you cannot partner with one or two facility where you will obtain some of these images and then you deal with it. I think it's better we consult rather than we give our clients that room to turning down an opportunity where you will be seen to have done a very excellent job. Exactly. So let us have more of this kind of conversation. Let us get to really fresh our memories in terms of what we learned some years back and then update those knowledges with my sister coming up with this kind of training. I think very soon Kotog may also have to start having this lab where we look out for even sponsorship, but as much as possible, the lecture today, I know many other colleagues around the country may have benefited, but my own colleagues at work here, about 11 of us, have stayed glued to the screen. And then we've picked one or two things that will make us better. And if anything, we've used MRI, we've seen what it will do. And until you try, you never can tell that clients can afford it. I mean, there are times that I have done surgeries here. The surgery is about 300,000, but they've spent money on CT scanning and MRI for close to 500,000. But when you look at some of the people we serve, that all is less than $1,000. And for them, it's still affordable in Nigeria than in the United States or in Europe. Thank you so very much.
Thank you. Thank you very much, Dr. Bala. You make the point very, very clearly. I was reading recently about Eco Hospital and how, clinicians came together and they, developed a business model. I pray that sometime in the near future, some vets will come together to do, things like that and challenge the status quo, because going forward, I know imaging is going to be so very important. Years ago, I mean, more than 10 years now, when I was in Louisiana, if the imaging department lost their server, the clinics had to shut down because there was nothing you could do without imaging. There was practically nothing. Everybody, those in the theater, those who are clerking cases, everybody needed imaging in one form or the other. And this is a place that had multiple radiographic rooms, multiple ultrasound rooms, multiple CT, MRI, and sometimes because they were mostly dependent on the internet, the servers would just crash. And once the imaging server crashes, the hospital, you just see people sitting around folding their arms, waiting for the server to come back up. So I'm trusting that this will, this will stir up as many of us as are interested to begin to do better work, better diagnosis, scientific diagnosis, rather than, oh, I saw this in 1922, it must be this, all those anecdotal diagnosing that we do needs to end.
Okay, thank you so very much, ma'am. So we have just, this will be our last question for you. Okay. From Dr. Zeletus is asking what happened to the generated energy during X-ray production, since the energy doesn't get destroyed, and also can he get a portable, affordable X-ray machine for a young clinician?
Okay, so yeah, X-ray production is important, and this is why radiation safety is very, very important. People who don't know about it should not be handling it. When you are creating an X-ray unit, a radiology unit in your practice, you have to call people who are, who are knowledgeable about it to put the things in place to ensure the safety of those who work there, the surroundings, the patients who will come. And that's the only way to preserve, the energy that is utilized in X-ray production. Regarding portable X-ray machine, that is such a difficult one, because X-ray machines are really, really expensive. And the smaller, the more portable they are, the even more expensive. Those huge machines are probably cheaper for you. My advice will be to look for a hospital that is getting rid of their old stock, that you can, buy and install. But portable machines, the new digital machines, are in the region of 20 million, 25 million. So they are not cheap. And I'm not saying that you can't afford it. I mean, if you are able to, for sure, you can contact me. I can put you in touch with the person who supplies machines to us, but honestly, for a young clinician or, a single clinician, it's a tough one.
Okay, thank you so very much, ma'am, for that wonderful feedback.
You're welcome.
I've learned a lot today, and the key takeaway for me is baseline data. Always ensure you have baseline data. Kindly refer cases. Ask for help if you need one. Diagnose. Don't miss the opportunity to diagnose issues. What's it called now? Presentations. Don't let machine deficits scare you. Stop relying on antidotes. And always remember the veterinary oath, and most importantly, be safe. Thank you so much for this. And at this juncture, I would like to hand over back to Dr. Bolande.
Thank you. Thank you, ma'am. So thank you so much for the engaging session. So Dr. Bala is just going to come and give us our vote of thanks and
Thank you
call
for
it a
having
day.
me.
Thank you.
Yes, I can hear you.
That's my professor in the making. Ola Davis. I don't know if she has run away, but I must thank you so very much. She was one of those deans that encouraged me to go ahead with this program. And I can tell you that we've been through a lot, but the students from your university that have not gone to SAR that can, interpret a lot of radiograph, carry out ultrasonography, and simply because we mounted on-site training amongst ourselves, where from time to time when you visit, we'll also hold you down for one day in doing this. And it has bridged a lot of gap. And I feel quite fulfilled Ibadan, trying to help us in making sure that you bring us up to speed with those simple technology in advancing veterinary care. On behalf of myself and my colleagues at COTOG, I would like to thank all of you, particularly the facilitator, for making it to this program. The discussions, the questions that you have asked, and the responses and some other comments are quite impactful. It has shaped the way we do things. And then my colleague that spoke before me said the key things are there. You don't have to know everything. You don't have to have everything. But if I have a particular equipment and you don't have, and you have that one, why not? Or if we all have, how can we even make the best out of it when we keep talking to one another? And coincidentally, this morning, very early in the morning, I was invited in an impromptu meeting with the human medics, orthopedics, and then they are trying to put up a very big surgical lab in collaboration with Ethicon UK. And then they are looking for vets who will manage that place, because in other crime, surgical labs are being run by the vets, while the medics go in there to also learn. And I jumped. I said, I am a vet. My two hands, the leg, and even the head is a vet. So they can have it. And the moment you have this, we can gradually come together, let the whole world know that we can do this. We have had to resolve a lot of surgeries here because the experts think if they take it to Europe, they are going to pay times 1 million times. And we did it, and it was very successful. Sometimes a learning curve, but the moment you do one, you do another one, 10, 12, you find out that you are actually very fulfilled and you become really an expert in it. And I think the moment we have this opportunity with the donors coming in, we will also encourage them to getting us the MRIs of this world and then the CT scans of this world, so that we can go the hub in terms of imaging, in making sure that hospitals in Port Harcourt, in Kaduna, in Ibadan, in Lagos, in Abuja, in Sokoto will see this as a go-to. It shouldn't be the one, like you have said, that the deficit of this equipment would scare you out of practice. So thank you so very much. And I'm also going to ask on behalf of the Kotog